all of you who joined the golf outing for the generous donation to the foundation. I'm going to talk to you a little bit about our work, but also specifically about what we're accomplishing in Virginia. And first I want to point out, as we talk about our work in Virginia, we do everything with partners, and we do everything in a coalition, and you all are part of our coalition in Virginia. So there's the Medical Society of Virginia, Virginia Nursing Association, Virginia Hospital Association, and Virginia HIMSS. So thank you as well for your partnership. I'm going to talk a little bit about Lorna. And for those of you last night, you already heard a little bit about this story, but I want to tell you how this foundation started and why we do what we do. Lorna was an emergency medicine physician in New York. She was the medical director at New York Presbyterian Hospital, on faculty in Columbia Hospital. And she came back from a snowboarding vacation to take care of patients in the first wave and to lead her department in taking care of patients during the first days of the COVID pandemic. We all remember the sights and sounds of those first days and weeks of the pandemic in New York, and that's what she went back to. And like many healthcare workers, she worked 20-hour days trying to care for patients, trying to care for her colleagues, figure out the PPE issue and the supply chain for her hospital, and trying to figure out how to treat this new disease, what was necessary, what was needed, because we were all learning at that point. She got COVID, as many healthcare workers did. And like many healthcare workers did, 24 hours after her fever broke, she went back in to work more. And she became so exhausted that she was really unable to leave her apartment. And her family, who are from Charlottesville, Virginia, worked with her friends from medical school and residency and got her out of New York, came back to Charlottesville, and she had her first ever mental health care hospitalization. And she expressed after she was discharged that because she had now received mental health care, she was worried she was not going to be licensed to practice medicine again. She was going to lose her license. She's going to lose her hospital credentials, and she wouldn't be able to lead her department, the one thing she'd wanted to do her whole life. And Lorna died by suicide. 12 hours after her death, the New York Times published an article about the cause of her death, the reasons behind it, in the New York Times against the family's wishes. And in the weeks and months and now years to come, first dozens and then hundreds and now thousands of healthcare workers have reached out to share their own experiences and to say, Lorna's not alone. Burnout is a huge problem in healthcare. Mental health care access is a huge problem in healthcare. And we know that the licensing and credentialing application questions that ask about a history of mental health care prevent people from seeking care. And that was the genesis of the Dr. Lorna Breen Heroes Foundation. It was in Lorna's honor, but also in response to those other stories. We know that healthcare workers are in a mental health crisis because they tell us, but we also know from the data. And so this data is from the Vital Signs Report from the CDC. The data is from 22, which is the last full country, full survey we have of healthcare workforce. And what we know is between 2018 and 2022, things got worse. Burnout increased from 34 to 46%, all comers. And we know there are some specialties, emergency medicine is one of them, where those rates are as high as 60%. That means if you go into the emergency department and you're being cared for, there's better than half odds that somebody who's taking care of you is experiencing severe burnout. We know that almost half of healthcare workers intend to leave their jobs. And for some people, that means they want to find a different job in healthcare, but for a lot of people, it means they want to leave healthcare altogether. And keep in mind, these are folks who have sometimes trained for up to 15 years to be able to do their jobs. So the opportunity cost here is huge. It's hard to retrain. And we know that healthcare workers have higher numbers of poor mental health days and of physical and verbal abuse than any other job class. Okay. So it is about Lorna, but we also have outreach from families across the country who have also lost loved ones. So on this slide, you see Matt Gall, Scott Jolly, Lisa Lerner, Mo Brown, and Tristan Smith, who are all healthcare workers who have died by suicide and who shared with their families that there was some aspect of their danger of getting mental health care that made them not feel comfortable or safe as a healthcare worker to receive mental health care. Whether it was being forced to receive mental health care from their colleagues at their hospital, the same people they'd be signing patients out to when they went back to work, whether it was the licensing and credentialing applications, whether it was going one town over and paying cash so that they could have anonymity in their health care and they wouldn't have to divulge their health care to their hospital, or whether it was the work environment itself in Tristan Smith's case. So our foundation has developed a way of thinking about the solutions, because we know there's a problem and we do educate on the problem, but we don't want to stop there. We want to say, what are the solutions for the healthcare workforce that will help with both, on the right-hand side, mental health care access, but on the left-hand side, burnout, because those are two different things. Mental health, depression, anxiety, substance use disorder, but all mental health conditions. Okay, well, how do we solve those? Well, we need to improve access, which means that healthcare workers need to be able to access mental health in the times when they're not working, which means as an ER doc, I'm working days, evenings, nights, weekends, holidays. I can't do a 3 o'clock on a Thursday afternoon every week, right? And that's how a lot of therapists or counselors work. So how can we be flexible and get people care when they need it? We can screen our workforce for suicidality and get them additional resources when they screen positive. And the American Foundation for Suicide Prevention has developed a workforce screening tool. And then we can make sure that we are removing those barriers to mental health care that are unique to licensed and credentialed healthcare workers, those questions on the licensing and credentialing applications. Before I mentioned that today, how many of you are aware that physicians have to answer the questions about their history of mental health care when they get hired? Okay. All right, because I heard you talk before, Dr. Simmons. All right, well, most people aren't aware of it. And in fact, our co-founder and president, Corey Feist, he was the president of the UVA Medical Group at the time of Lorna's death. He wasn't really aware of what a burden these questions are to healthcare workers, and that it is the #1 reason why people don't seek care. Okay, so on the left then, you see burnout. Burnout is an occupational hazard, and it is not unique to healthcare. Anyone can experience burnout. In fact, about 1/4 of the people in this room have probably experienced burnout, just based on statistics. Okay, burnout is the mismatch between your work demands and your work resources over time. It is a workplace phenomenon. But I would argue that that mismatch is different in both type and degree in healthcare, because the work demands are literally life and death. And when the resources don't meet the demands, there is a moral injury that occurs because you are unable to give people care when they are dying, suffering, in pain. So when you want to address burnout, okay, I'm an ER doc, you can take the girl out of the ER, but you can't take the ER out of the girl. So I think of like a bleeding patient, a stab wound in front of me. That's our healthcare workforce right now. They're not doing so great on the mental health crisis. So when someone's bleeding in front of you, the first thing you do is you hold pressure, right? Slow down the bleeding. First aid. That's individual support for burnout. So when people are experiencing burnout, they can benefit from peer support. They can benefit from coaching. They can benefit from counseling. That's individual support. If you don't address the source of the bleeding, though, that patient is still going to die. So how do you address the source of the bleeding? You reduce the work demands or you increase the work resources. Okay. There are work demands that everyone in healthcare signed up for. I went through 4 years of undergrad, 4 years of medical school, 5 years of residency, 2 years of fellowship to be able to be there for people on the worst day of their life, to be able to diagnose and treat disease and to relieve suffering. That's the job. We don't want to change those demands. But then there are the demands that are not necessary. They are the demands of an inefficient workplace environment, an EHR that's designed really well for billing and not always really well for patient care or for clinicians. There are systems of how you get paid that are not really designed for excellent patient care, but for profit. And those are the demands that can be reduced. So you can give people individual resources, you can reduce the unnecessary demands, and that's going to help address the source of the bleeding. And that's when the patient survives, okay? Ideally, you prevent the wound in the first place as well. Leadership and culture is what makes these solutions feasible in organizations. And I'm going to talk about what many of your hospitals and health systems in the state of Virginia, the Commonwealth of Virginia, sorry, I'm a Michigan girl, so Commonwealth doesn't trip off the tongue. The Commonwealth of Virginia are coming together to do. So let's talk about how we're doing that. Our co-founder, Corey Feist, told me that you can only do 3 things, and it's really helpful if they start with the same letter. So that's what we're doing, okay? We are accelerating solutions, we're advocating, and we're advancing collaboration. And I'm going to talk about our work in each of those terms, but we're going to drill down specifically on collaboration because that is what has been so powerful in Virginia. And that is what is starting to move the needle in Virginia in terms of the work that we're able to do together. In advocacy, the first ever federal legislation to look at the mental health of the healthcare workforce was passed 3 years ago. It's called the Dr. Lorna Breen Healthcare Provider Protection Act. And it's up for reauthorization right now. In the reauthorization, there is a focus on reducing administrative burden. So in advocacy, we are specifically looking at how do we reduce the burden of documentation, how do we reduce the burden of EHR systems, of cybersecurity, all of the things that add incrementally onto a healthcare worker's day and gets in between them and the diagnosis and treatment and relief of suffering for their patients. So that's where all of you come in because that's the work you all are doing. And even if you think that something is just adding a minute onto a healthcare worker's day, there are 100 other initiatives that are also adding a minute. And those days are already over full. So thinking about how we can take away that burden is important. So that's one example of advocacy. And in advancing solutions, we talked about the Impact Wellbeing Guide, and you're going to hear more about how Virginia is implementing that. So we're going to go in the way back machine here. We're going to go back 4.5 years ago when the VHHA, the Medical Society of Virginia, the Virginia Nurses Association, and Virginia HIMSS came together and said, we need to do something about the healthcare workforce because we can see that this is critical and that change needs to happen. And together, Virginia decided on 4 actionable commitments. So the first was that they were going to seek to understand both the individual but also the systemic drivers of healthcare worker burnout. Understand more. The second was to evaluate and enhance organizational efforts on professional well-being. Okay, so how can we help make things better in our organization? The third was to participate in a statewide learning activity. This is innovation because states had not been doing this. So Virginia has really been leading the way in the thinking around this. And the fourth was to identify a specific area for focused improvements in our organizations. And I'm going to give you guys a spoiler, is that that specific area is EHR optimization for human factors. Okay. So caring for Virginia's caregivers, then, was the output of those 4 actionable commitments to build a learning community of the hospitals and health systems throughout the Commonwealth to come together, to understand the drivers of burnout, what organizations can do about those drivers, and then to come together in a learning community to start to change the learning environment, the care environment for healthcare workers. And so one of the outputs of the Dr. Lorna Breen Healthcare Provider Protection Act was the Impact Wellbeing Guide. And the Impact Wellbeing campaign was initially developed to be an awareness campaign for healthcare workers and for healthcare leaders to help them be more aware of the fact that burnout is a problem. And I don't know if you all have ever had the opportunity to be involved in a world-class marketing and communications campaign. I had not previously to this, but there's a lot of discovery that happens at the beginning. There's online bulletin boards, there's in-depth interviews to really understand what your target audience already knows, what the gap is between what they know and what you want them to know, and how to reach them. Okay, so it was during that process of in-depth interviews, of online bulletin boards, learning about what healthcare workers already knew and what leaders already knew, that we learned that healthcare workers already know about burnout, turns out. Not only do they know about burnout, they're actually tired about hearing about burnout, and what they want to hear about is solutions and what their organizations are doing to make things better. So that lesson came loud and clear from the healthcare workforce. Now, what do you think we heard from leaders? We heard, gosh, we'd love to do something about burnout, but we don't even know where to start. Because it can seem like when you wake up on any given Tuesday morning, to fix burnout, you need to fix the whole US healthcare system. And that feels like a lot for any given Tuesday morning, for any given leader. And so they wanted a guidebook with signposts on what to do. And so what the Impact Wellbeing campaign became was the Impact Wellbeing Guide. And what this says is, okay, burnout is an elephant. It is a huge problem. And if you're gonna eat an elephant, you need the first bite. Here's the first 6 bites that you need to take of this elephant to get the work moving. And here's who you need to invite alongside you to do this with you in your organization. So this is the guide to elephant eating, okay, for professional well-being. I'm a vegetarian, so this is actually like a deeply uneasy metaphor for me, but it works. Okay, so caring for Virginia's caregivers, then, is the implementation of the Impact Wellbeing Guide. They were co-developed at the same time with the Dr. Lorna Breen Heroes Foundation. So Virginia has really been an innovator, not only within the Commonwealth, but nationally, leading this work and helping to develop this work. Okay, so in caring, C4C is what we call caring for caregivers. So if you see that acronym, that's what it means. I heard you saying earlier that the acronyms in healthcare are hard to learn. I'm married to an IT guy. He's a project manager for Google, and I'm here to tell you that there are as many acronyms and jargon in that specialty as mine. So the first step is to break down barriers to care seeking for healthcare workers. Okay, and we talked about what those barriers are. Invasive and stigmatizing questions about mental health care in licensing and credentialing applications. The second was to learn the well-being systems approach, because that word well-being means different things to different people. If you asked probably anyone in this room 10 years ago, what does well-being mean to you? You'd be like, I don't know, like eating a healthy meal and getting a good night's sleep and maybe doing some yoga or meditation, right? It's not changing the systems that we work in. and removing barriers to care. So this is the phase 2 then, is thinking about that systems approach and educating people about the systems approach. And then the third is to integrate the concept of systemic well-being into operations. So that's what's happening in Virginia right now. And I'm going to talk about what phases 1 and 2 have looked like in the Commonwealth and what we're doing in phase 3. So let's talk about breaking down barriers to help seeking. And I'm going to sound a little excited when I'm talking about this, and it's because organizations have been trying to get this to happen for decades. I was just talking to an emeritus professor, a psychiatrist from the American Psychiatric Association. She said, this was work we were trying to get done 25 years ago, because we knew that asking these questions actually made the problem worse, put clinicians at risk, and put patients at risk. But we couldn't get any traction. So there was small amounts of change happening and really great thinkers trying to get this happen. And what happened in Virginia was that there was a moment with the pandemic where a movement could get started. And that's what happened. And so first, the licensing applications for all licensed healthcare workers in Virginia were changed via legislation. So a law was passed saying you can't ask invasive language about mental health care on the licensing application for any licensed healthcare worker. That included 62 different licensed professions, including dietitians, for the dietitian family members in the room, and PTs, OTs, CRNAs, nurses, pharmacists, physicians, okay, everybody. 500,000 people changed with one stroke of the pen. And then the hospitals issued their own challenge to each other as part of Caring for Virginia's Caregivers, saying, we are going to eliminate this language from our hospitals and health systems. And within 10 months, 75% of the hospitals and health systems in Virginia changed their language on credentialing applications. And you guys work in healthcare, you know that change doesn't usually happen that fast. But that's what happened in Virginia. And in fact, HCA had a couple of hospitals in Virginia and wanted to participate. Those hospitals wanted to participate in the challenge. But all of HCA does their credentialing for all of their hospitals together. And so they changed their credentialing application for all of their hospitals, the largest private health system in the country, because of the work happening in Virginia. Okay. So then, operational and clinical leaders from these 12 health systems engaged in learning, online learning, about the systems approach to professional well-being. This learning included experts from around the country, internationally, and locally. So Corey and I participated in the education, also Pam Cipriano. So if you're from UVA, you may recognize that name, but she is also an international nurse leader. John Ripp, who leads an organization with every chief well-being officer that leads an enterprise and an organization above a certain size called CHARM, also participated in this. And then Dr. Nathalie Duget, who is a hospitalist. She had a camera crew following her around in the pandemic. And the footage from her experiences early in the pandemic became a movie called The First Wave. It's available on Hulu. It won an Emmy. And so she went from a recently graduated hospitalist resident, right, to a Emmy award-winning documentary star. And she has taken that experience and her experiences during the pandemic to help educate about what healthcare workers now need to support their mental health. So your healthcare leaders, operational and clinical, went through this education, and we had great engagement. So we had a lot of completion across the state. 85 leaders completed the entire curriculum, and about half as many as that completed almost all of it. So then we have made real change in licensing and credentialing. We've set the stage now where there's a statewide vocabulary around the systems nature of professional well-being. So what are you going to do with that? What do we do next? And that's where the learning collaboratives come in and the learning communities. And we are right now in that third phase of all-in caring for Virginia's caregivers. So many of you will have heard of the triple aim, right? The Institute for Healthcare Improvement put this out over 15 years ago at this point. The triple aim in healthcare is patient experience, outcomes, and efficiency. Okay, so you want people to be healthier at the lowest possible cost and have a good experience getting there. That's the triple aim. The quadruple aim adds in the impact of the work on the workforce and says without a healthcare workforce, you don't get healthcare. So we need to make sure that we're thinking about our healthcare workforce and preserving them. And then the quintuple aim says we need to look at populations and make sure that healthcare outcomes are fairly distributed, right? That if you have appendicitis in Montana or in Richmond, you have the same health outcome. If you are pregnant and you have black skin or white skin, you have the same health outcome. So that's the quintuple aim. And what we know right now is that health equity is not equally distributed. So quadruple aim quality improvement projects say we've focused on the first three and we're not doing so great on the fourth one. We need to focus on the fourth one so we can get to the fifth one. We need to start thinking about our workforce so that we can have a workforce that can help distribute health care more equitably. We need our outcomes to improve for everyone. And so we do need to focus on our workforce. And so quadruple aim quality projects then say, okay, how many of the hospitals and health systems do you work in have some quality improvement project going? Okay, every single one of you guys, every single one of you that works with the hospital or health system. Usually dozens, if not hundreds. There's an apparatus within your organization for quality improvement. It is necessary, things move fast, and lives are at stake. Most quality improvement projects do not have a measure of the impact of the project on the workforce. And so what happens is you just keep adding. You just keep adding documentation or work or a form or a process to improve the quality. But what happens is just like a garden that you never weed, all of a sudden instead of a fruitful garden, you end up growing weeds. And that's what it feels like to practice medicine, is that you are trying to do patient care in a garden choked with weeds because we haven't looked at those processes and eliminated the waste and said, how can we do this without adding something more to the healthcare workforce? So our learning communities are focusing on quadruple aim processes for EHR. And so how do you then take a group of people and say, we're going to eliminate some of this waste? So we've said, we're going to take one project first. So just like when you start lifting weights, you don't just go up to the rack and put 200 pounds on the bar and start to bench press it, right? Maybe some of you guys do, I don't. So we're gonna start with one. I like that. I like that camaraderie at that table over there. Like, that's what I would do, yeah. All right, so we're gonna start with one project and we're going to teach it systematically. So we have a well ops process. Like any good jargon thing in medicine, this is an acronym, and we'll talk about what the acronym stands for. And it serves as taking the quality improvement project, that lens of how we do quality improvement, and just shifting it 10 degrees. Okay, not going, we're gonna do this whole different thing, which is professional well-being, but saying we're going to take our existing infrastructure and just look at this through the lens of the impact on the workforce as well. Okay. So we do this through a learning community, which means that there is a team in the 12 health systems within Virginia that are participating that is leading this project. And we've asked the teams to be very mindful about including folks from across the organization in the organizational, the clinical C-suite, right? So representation from the CMO, the CNO, the CMIO, right? And then also the operational C-suite, CHRO, COO, COO, CEO. And then also looking at your clinical leaders. So who are your chairs? Who are your nursing leaders? Who are your pharmacy leaders? And making sure to get them involved in this education and process as well. And then we asked for a team leader who will be the interface with the learning communities. So we said you can do a new project, or you can use an ongoing project. And it's intended to improve the healthcare worker environment. It needs to be a project that's open to share. So if there's something that is like very IP-oriented, maybe this isn't the right project. But if it's process sharing, if it's integration into your systems, please, please, please bring it. And Virginia has said we want our focus to be EHR optimization. So how to alter, change, improve the EHR for, yes, quality, and also the impact of that change on the workforce. Why EHR optimization? There are so many things we could focus on. Well, when you ask healthcare workers what contributes to their burnout, EHR optimization wins. Okay. I am just old enough in my career that when I started practicing medicine, I hand wrote my notes, I hand wrote my orders, and I talked to my team constantly. So I actually lived through clinically this transformation from you just used computers to look up the lab values, right? It was essentially a spreadsheet that the lab entered things in and I looked at, to everything I do being on a computer. And there are some good things that have happened, right? The access to notes, nobody has to like come up from the basement with a big box full of a patient chart. You guys remember that? Somebody's not getting their workout anymore, right? So I have access to notes. I have access to records, to the radiology results, not just from my hospital, but other hospitals. Like there are real advantages, but these systems have not been designed for people. They've often been designed for billing. And people have suffered, patients have suffered, and healthcare workers have suffered as a result. So that's why. Here are the team leads from the participant organizations. So if you work within one of these organizations, I want you to take note of the team lead. And if you are not already involved in the project at your organization, please introduce yourselves to these people and say, hey, I want to get involved. Because we want the state to move forward and to share with each other and really benefit from the knowledge and the expertise that you all have. Along those lines, I know that there are people in this room who are on those teams and involved in those projects. If you are, could you please stand up right now so that people can see you? All right. Thank you. Thank you. So if you're in a learning collaborative team, thank you. If you're in a learning organization, thank you. And please, please, please reach out to your team leader to offer your assistance. The team leader attends learning community sessions. That's every other month. They are the point of contact for communication, and they submit the outputs. And I'm going to tell you about the outputs here in just a minute. The entire project team contributes to the planning and execution and is also welcome to attend the learning community sessions. Those are open sessions, and I'm sure that they would appreciate any help and also any expertise that you all in the room can lend. Our community has virtual shared learning experiences, and so there are also in-person gatherings. This is one of them for you all to interface with the team leaders and with the team members, but also to hear about what's happening. We will also be at the VHHA meeting in November if any of you are attending that as well. And then there is a digital curriculum. Okay? The digital curriculum is on a platform called Symphony. And we call our learning management system Symphony because it takes the winds and the strings and the percussion, right, all working together to make this work. So you guys can think of yourself as one of the sections in the symphony helping to make this work. The shared sessions are about 90 minutes long, and we will be sharing what's happening in one of the hospitals and health systems within Virginia. There will be a national expert presenting on an area related to EHR optimization, and then the team leaders will also share what barriers they're facing in their organizations, how they're overcoming those, and what the successes have been like. We have community resources that we've put together. So Chartis has actually put together a library of here are the top 20 things that organizations have done to improve the workplace environment for doctors and nurses. So we have a video library there. We have a case study that has used the WellOps curriculum, which I'm about to go over, and then also resources not only on EHR optimization, but also on healthcare worker well-being from the holistic perspective in Symphony. Here's what WellOps is, okay? And this is not brain surgery or rocket science. And my best friend in medical school became a brain surgeon and was married to a rocket scientist, so I can say that definitively. But what this is it's change management. Okay, this is how you get that 10-degree shift from quality and safety to include professional well-being. It's thinking about who's on your team. Are you really incorporating the voices of the end user? Are you thinking about who needs to be on the team globally? Then it's thinking about what your current state actually is. Are there places where you're doing this excellently already that you can expand? Because often what happens with change is there's something that's working well and it gets ruined because we change. Of these letters has an output. This is what the learner's journey looks like in Symphony. And so, for instance, for who is on the team, the output is a team roster. Here are the names, here are their roles, and here's the role they're playing on the team, okay? So that's what the team leader puts into Symphony as the output for W in WellOps. Each one of these letters has an output, and at the end, when you add up all the outputs for S, share what works where it works, you have a case study, okay? So the outputs for WellOps build a case study that then we can collate, we can promote, we can publish, and we can share how Virginia is being an innovative leader for the country in this work. Okay. So the team leaders download a template, they fill it out, they put it back in. And we are going with this right now. So we've had our first learning community meeting. Projects are getting started and underway. And please connect with your teams, offer them your assistance, because they need your expertise, they need your perspective, and you are one of the folks who needs to be, at the very least, on the informed part of the stakeholder chart, if not actively engaged and involved. Thank you so much for your time and your donations with the golf outing yesterday. There are cards at your table with additional information about the work that's ongoing in Virginia and opportunities to get involved. I encourage you to reach out to either me or to our Chief Experience Officer, Melissa. And for those of you who are involved in the work, you'll know Melissa's name because she does a lot of our communications. We are happy to answer any questions. We are happy to talk to you about how your organization can get involved even now, if it isn't already. And I just thank you for your time and your attention, and I'm happy to answer any questions. All right, you guys get 13 questions, so go ahead.
So I'm going to ask the same thing that I did to Dr. Moret, which is how do we as individuals support? You mentioned that there's legislation now. Is there a way for those of us that want to advocate? How do we help get that shepherded through our government?
Thank you for the excellent question. drlornabreen.org has a section called Get Involved for organizations and for individuals. Individuals can do one of several things. They can write their representative in support of the legislation. And I will say Senator Kaine has been one of the sponsors of the legislation, both in the initial legislation and also in the REAUTH, but so has Jen Kiggins. And so Virginia is well represented. And if your representative has already signed on, you can thank them. So that's the first thing. Often I will say if you are a clinician, you can write your state medical or nursing board to change, but Virginia has already done that. So go Virginia, okay? You can donate your time, your talent, your money. You can encourage your organization to philanthropically support the foundation. And if this is an area that you are passionate about, that you want to do more in, you can become an ambassador. One of the areas that we advance collaboration is we have over 150 healthcare workers and families of healthcare workers who have died by suicide who serve as ambassadors and help carry this message forward. So thank you for the question. 12 more. Yes. I need a catcher's mitt because that's a softball. Yes, of course. So safe staffing ratios are critical. When you talk about work demands and work resources, right? The number one work resource is enough people to do the work. And there is probably, you know, like in chemistry, how there's that triple point between boiling and condensation and sublimation. There's probably a triple point between patient experience, staff experience, and expense, and we haven't found it. You know, we haven't found that triple point. So data analytics would be a great place to find out where that triple point is. All right, 11. Any questions? Nobody's going to ask me my bench press? Yes. That's a great question. So the question was, is there any education for patients on how to be better, I guess, to their healthcare workforce to understand? So many of you guys in your hospitals will see like a sign and it's like, hey, we're all doing our best here, right? Like, please don't be a jerk, right? So the hospital, that's paraphrasing, obviously. Somebody's, has signed off on that language and wouldn't sign off on mine. But some hospitals are starting to educate in that way. But as a foundation, we're actually launching a Stop the Stigma campaign in the spring. And there are different stakeholder groups for that campaign. There is a healthcare worker and family group. There's a healthcare leader group, but there's also a general population group. And all of us could be patients tomorrow, right? And so just even understanding that, for instance, when you go in the ER and you have a broken ankle and you're waiting longer than you want to be waiting to be seen, like it may be because there's a 3-year-old being coded, right? And then if your doctor seems distracted, I mean, that's where they came from. And so it's actually a real example where I ended up having to have like a patient experience service recovery conversation with a family, and I got permission from my boss basically to tell him what was going on. And I think in general, we can be more empathetic to our healthcare workforce. But I will say, like, this issue of burnout is a big one because there are 3 characteristics of someone experiencing burnout. You are exhausted, which means you're tired, and you're tired in a way that rest doesn't help, okay? So you have exhaustion. You have reduced efficacy, which means you feel like what you are doing doesn't make a difference. You just think about that for a healthcare worker, right? And then the third is depersonalization, meaning you don't feel like you are a human being in your body caring for another human being. You feel like you are going through the motions or doing a mechanical task. So when you are depersonalized, that connection, that human connection, degrades. And so that's where patient experience ends up falling off as well. Thank you for the question. Yes, 10.
I think that last point you mentioned sort of highlights, at least in my mind, where there's a passing, because what Dr. Moray was mentioning earlier was that there's a hesitation by the physician and provider community or clinician in general to accept the help impending from AI, right? We're sort of resisting it as a community. And it sounds like you'll need it a lot to need that help. But that third point of depersonalization, is that what's creating that? Or is it fear? Is it hesitation? It's probably a lot of things, but do you think that the depersonalization aspect is what's driving some of that? Where they feel like if I give this task up to an AI, I'm further mechanizing my otherwise human task?
In the 30 seconds I have to answer that question, I don't think I can do it justice because that is like a symposium's worth of material, but it's an excellent question, which is what makes people reactive to change instead of embracing of change and helping to optimize change? Like people who are in a damaged position are not embracing innovation necessarily, right? I will also just, because I was a history major, I'm gonna indulge myself for 30 seconds. 100 years ago, physicians had very little they could actually do to fix somebody. We didn't have antibiotics, guys. We didn't have antibiotics. You could lance an abscess, set a bone, and pull a tooth. Those were the best things you could do. Maybe some birth maneuvers, but you were just as likely to give somebody sepsis, 200 years ago from a birth maneuver as to save the mother and the baby because you didn't wash your hands, because we didn't have the germ theory of disease. So for millennia, the role of healthcare workers and healers was to reduce suffering by witnessing the human experiences, to being alongside somebody, and to help provide some context to those. So now we have stuff we can do. Right? We have vaccinations, we have surgeries, we have antibiotics, we have chemotherapy, we have enhanced diagnostics. And maybe we've lost a little bit of that reduction of suffering. And so there's this pendulum between those two ideas, and AI is like adding a third axis to the pendulum. So that's another thing, that's another half day of the symposium that I'd like to pitch as a topic. All right, I said I'd give you guys 9 more questions, but I'm getting no more questions. So thank you for your time. Sorry for your comment. It's my pleasure. Thank you. Thank you.
Thank you.
Do you want this?
Thank you, Stephanie, for the great message. I just encourage each of you as providers and vendors, when you're designing systems or products, keep this all in mind. It's so important, such an important message and a great cause. More information here, and the QR code goes to donations, and it is tax deductible. Thank you. We'll hear more later on the how-to with design, human-centered design.